Hello, I'm Dr. B, and this is Nate, my client. And we are today going to do a soft tissue palpation assessment of the shoulder girdle. That's the what. The why is to establish normal relationships with anatomy, normal relationships between soft tissues and bony tissues, today focusing on the soft tissues, and also to determine if there are any sort of pathologies. When we are palpating, we want to be firm but gentle. If I'm kind of tickly a little bit, it may irritate and communicate lack of confidence on my part. Firm provides a bit of a deep pressure, which actually is soothing, stimulates the parasympathetic nervous system, homeostasis, and yet it's confidence, and that's important. Before we do that, I will speak to, we are not masked up, because Nate has had COVID and I am symptom free. I have had the first shot, and it's important to me to be able to see the countenance, especially having worked with the athletic population, because they have paid such a price and they are such competitors. Their mouths will often tell you something different than their face or their countenance will, and you need to be able to tell that. They may not indicate that something hurts, but their face will tell you when it's tender, and hopefully you'll know their personalities to pick it up. We always start by cleansing the hands, and that's actually a practice before COVID came along. I don't want to transmit anything to my client, and when you're done with your assessment, you'll cleanse with your hands again. Very well. Today, as mentioned, we're doing a soft tissue assessment. The shoulder girdle, according to Hoppenfield, and things may vary depending upon what clinician you work with, but this is baseline and well-respected Hoppenfield. I would encourage you to follow the figures and do highlighting as we go through with this. The shoulder girdle, as far as soft tissue, is divided into 4 zones. Zone number 1, and in my course, it's not so important that you know numbers of zones. For example, the 8 ankle foot, we have 11 zones with just soft tissues. So the numbers aren't so important, but the region is, and name it by the region. Zone 1 is the rotator cuff, located here. Zone 2 are the subacromial subdeltoid bursa, here. Really, if I'd have done it, I'd made both of those the same zone, because we're doing about the same technique. Zone 3 is the axillary region, and zone 4 are the major muscles of the shoulder girdle. To begin with, I ask permission to touch the muscles and bones of your shoulder girdle to see if relationships are right, to see if the anatomy's right, and if there's any potential pathologies or change in function.
Yeah, that's right.
You have all the power here. If I approach anything that makes you uncomfortable, then you stop me before you're uncomfortable, okay? If you're working with a lady, you'll have her keep the t-shirt on or a sports bra, and be very careful now, because in this society, it's so happy, I will say, as far as my class goes, and we're not here to get ourselves in trouble or harm them. We're here to serve their needs. As we approach the mammillary lines, we've got to make sure they feel safe, and you know you have all the power here, especially with the woman. Zone number 1. Hoppenfield wants you to approach it from posterior. I will do it from anterior because I want to see the countenance. We are going to slightly extend the shoulder and make sure the client's giving you their arm. You see that? That's still not natural. Loosey-goosey. It ain't easy. It ain't easy. I'll bet half of your clients won't be able to initially give you the limb. So there, you can see it flops immediately when I let go. I know I've got control of the limb. If he's holding it, muscles or soft tissues that I'm assessing are now taut. They're generating tension, and I'm not going to get an accurate measure. So he's loose, and these structures I'm after with zone 1, rotator cuff, are deep to the anterior deltoid. On the back side of the shoulder, we have the supraspinatus that runs through the supraspinatus groove. Help me.
It's the Spinous fossa, there, over the top and onto the greater tuberosity. Then that's the S of the fore rotator cuff. Then we have the infraspinatus immediately underneath the spine in the infraspinous fossa, and then we have the teres minor. It's minor because it comes off and only runs to the greater tuberosity. Teres major comes off the inferior angle and clear through the armpit and attaches around front. So, SITS. With zone 1, we are testing SIT. Supraspinatus, infraspinatus, and teres minor. Because we can palpate them, you're not able to truly distinguish them from the overlying anterior deltoid. But you will know that you're on them, and you will elicit pain if there's a problem. Or if there's a gross tear, you may palpate that. But otherwise, you can't tell supraspinatus from infraspinatus, from teres minor, from deltoid, from subacromial bursa, unless they're pathologic. But you're on them looking to elicit pain. Having said that, SIT, those are the ones we're feeling, supraspinatus, infraspinatus, and teres minor. If we establish there's something going on there, then there are stress tests we can use to isolate which of those it is. That's another video. So, zone 1, acromion process. We're going to step off slightly lateral and anterior. Slightly extend the shoulder and it's relaxed so that I can get deep into the muscle. With bony palpation, we learned to internally rotate and externally rotate. Here, internally, I can feel the greater tubercle. There's the bicipital groove and the lesser tubercle. Now, out on the greater tubercle, I'm going to probe around on there, watching his countenance and listening with my fingers for any tenderness, temperature, texture, landmarks, bony and soft, bony in this case, contraction, and creases. No, consistency. And that's what I'm listening for. I can feel the long head of his biceps roll into my finger, but that's another zone. And I'm not eliciting anything. Moving on to zone 2. Zone 2 is right in the same place. Deep to the acromion process, we have biceps, we have rotator cuff, we have capsule, we have ligaments, we have deltoid, lots of soft tissue structures, and a lot of impingement. When the greater tuberosity comes up under the acromion process, there is impingement. So you try to abduct A24 with your hands superior like this, it gets tough. But as soon as you externally rotate, you could go easily. That's because as you've come up, abducting, the greater tuberosity is impinging on the acromion process. And you've got a lot of soft tissues in there that get pinched. So you externally rotate, it moves the greater tuberosity out of the way, so you've then got room. Well, to protect from all of that friction, deltoid, on the rotator cuff, on the long head of the biceps, etc., we have a synovial bag called a bursa. It's just a ligamentous sac that has lined with synovial membrane, produces synovial fluid. You shouldn't feel anything if it's healthy. You're on the olecranon bursa. If you palpate the patella, you're on the suprapatellar bursa, but you can't feel anything. It's healthy. So we're going to roll off anterior and lateral once again. Under the acromion and over to the down into the bicipital groove, we have the subacromial bursa. Well, I'm right on the same place I was for the rotator cuff. Should have been zone 1 for both of them, because it's the same technique. I'm feeling for spongy or boggy to control that. And the subdeltoid bursa comes off more lateral and runs down under the deltoid muscle for a little ways. Again, we're just looking for gushy. When a bursa is pathologic, healthy is a Ziploc sandwich bag with a little water in it so that you can slide the edges, the borders together. When it's pathologic, we're hurt, we gotta protect. And the only thing a bursa does is produce more synovial fluid. So then it becomes a bag half full of water instead of just wet the lining, and then you can feel boggy and spongy. And or elicit pain. And if you do get positive for tenderness, then it might be rotator cuff if you don't feel the boggy, or even if you do feel the boggy. So then we go to special tests, which is another video, to distinguish one from another. And you can distinguish one from another. Zone 1, rotator cuff, SIT. And zone 2, subacromial subdeltoid bursa. Zone 3 is the axillary region. Again, you might want to clean up. Yes, you're going to get body fluids here. If you've got any open wounds or anything, glove up. And if you want, this is now dry, the person can wipe out their armpit if they're conscious about it. I'm going to slightly abduct. This is zone 3, the axillary. Relax. Good. You can see now I've got it. It's down, where before it lingered. If you can't get them to relax, have them use the other hand, touch their thumb to pinky. This is a method, not the method, and count backwards from 100 by threes. 100, 97, 94, oh dear, 91, 88, okay? That focuses here and gets them relaxed here. Abduct the arm, insert the fingers into the axillary region and relax the arm. At that point you can go up higher. The armpit is a quadrilateral pyramid. Pyramid, not meaning 3 sides, but it's apexed. But you've got 4 sides. The medial border is the ribs. You can feel ribs 2 through 6, and I'll hold you for that. You can actually count on the border. Also on this border is the serratus anterior. Now the serratus anterior and the pectoralis major are primary muscles in zone 4. We're in zone 3 now. But I'm not going to do this and be here and leave it and come back again. So I'm going to include the serratus anterior in zone 3 while I'm here. So medial border, ribs 2 through 6. Serratus anterior comes around from the anterior aspect, vertebral border of the scapula, and attaches to ribs 1 through 8. 1 through 8. These are the fingers. Hold up and push your arm down a little bit. The fingers you see coming around in the ribs right there is the serratus anterior. Its job is when you are doing a bench press, horizontal work, etc., this muscle keeps the scapula into the rib cage so it'll glide around this way. If it's weak and you use it, it will flare out off the back like this, called a winged scapula. That's a specific test that we'll do when we do special tests. So, medial border, ribs 2 through 6, serratus anterior, just the soft tissue anchoring to the ribs, 1 through 8. And you can't feel it if it's healthy, but there are also lymph nodes localized there, a group of lymph nodes. If there's any infection from this point distal, they will be swollen because the lymph node has been told by the T cells that there's an invader and this is what they look like. All points bulletin, build the antibodies. And so they become gorged and enlarged as they're building more antibodies in the lymph nodes, so you can feel slippery grapes. If you feel slippery grapes, that indicates that there is an infection distal to that point. Medial border, ribs, serratus anterior, shouldn't feel, but there are lymph nodes. Posterior border, while you're here, slide the thumb into the armpit, drop it down, and you've got the latissimus dorsi. Lean forward. With the latissimus dorsi, you want to do a 5-finger sweep. Pivot off your thumb, and you're watching their countenance. Aim for the inferior angle, because it does cross the inferior angle, and then it's this band that comes all the way down to lumbar fascia and even the iliac crest. Looking, I'm not feeling anything abnormal, and he's not indicating there's any problems. posterior wall, zone 3, axillary. Anterior wall, be careful here, we're approaching mammillary line. If it's done properly, you're not going to be a problem. Empower you that you have all the power here. I'm going to sweep down your pecs. I shouldn't touch anything personal. You stop me if you get uncomfortable before you're uncomfortable, okay? Thumb in the armpit with the other hand. Anterior wall is the pecs. It webs across here, and then from here with your thumb in, you're going to sweep all the way down. It ties into the inferior angle of the medial 2/3 of the clavicle. Don't just sweep. You can't hear anything there. I'm palpating and looking for any fibers that are tender. It gets to the sternum, actually the cartilage, sternocostal cartilage here, and I'm walking my fingers down and squeezing. Getting to the mammillary line, or the mammillary gland, you don't actually touch it. And if you do, it's with this part of your hand where you're not really feeling anything anyway. Watch their countenance. If they get a little uncomfortable at all, you stop. There is a condition where you overuse your pecs, you're lifting or benching or something, and you have tenderness right here, not on the sternum, but here. It's called, spelt with the T, T-I-T-Z-Y, Tsetse syndrome in Hoppenfield. Costochondritis, okay? You've inflamed this area. You've ticked it off. That is the third border, medial border, posterior wall, anterior wall, lateral wall, basically is just the humerus, and relax the arm. You have biceps brachii and you have triceps. Between the two, you can step in and feel the medial border of the humerus. If you probe around a little bit, you can feel me rolling them right there. What I'm after, you've got the brachial plexus nerves, the subclavian axillary artery, and at this point, brachial artery. Relax, please. And I'm listening with my fingers diagonal, so one of them will pick it up. Right there, his pulse in the brachial artery, to test the integrity of circulation to that point. Okay? Those are the four borders of zone 3, axillary. Now we are going to do zone 4, which is the primary muscles of the shoulder girdle. We will subtract pex major and serratus anterior out because we included them in zone 3. And you'll find, as you shadow your supervising clinician, that their 30 years of experience have taught them that this works better than this. So, like myself, I include those in zone 3. Just so that you assess them, you're covered, whether you do it in zone 3 or zone 4. With this, we are going to take an anterior view, and the sternocleidomastoid, named after its attachments. The mastoid process, it comes down and attaches to the sternum and to the clavicle, sternocleidomastoid. Push against my hand, please, and you'll see where it attaches here, and relax, and here, and I'm going to assess both of those, and relax. Now I'm going to palpate. Now when you do your annual physical, the doctor will palpate right here. This is clinically significant. Anywhere Hoppenfield speaks to a clinically significant, you make note. He may say, it's because it could indicate this, or this. Where there's a list, you note it, or its clinical significance is. It's threefold at the sternocleidomastoid why that is important. One is we get hematomas, pools of blood here, which makes the muscles go into spasm, and it turns into wry neck, or you wake up in the morning and you've got a stiff neck. Personally, I truly don't see the association between we get hematomas and he ties that to wry neck. I don't see it, but okay, be aware. Also, we have lymph nodes here. That's why the doctor is checking. When she's doing your annual physical, they're listening for, hopefully nothing is normal. But if you've got slippery grapes, now you've got an infection somewhere from here out into the extremity. Okay? Tonsils or a lymph node, an infection, strep throat in the throat. Okay, so we have, it's clinically significant because of hematoma or Ryeneck, or lymph nodes may be swollen. There's another condition Hoppenfield doesn't speak to called torticollis. It means turtleneck. This is where you sleep wrong at night and you wake up and you just can't move your neck. The muscles are in spasm for some reason. Okay, we won't get into therapy, but torticollis. Hoppenfield mentions the lymph nodes, Ryeneck, or hematomas, and finally whiplash. These muscles, when this 8-pound bowling ball continues at 70 miles an hour that way, but the seatbelt stops all of this, these muscles are going to be eccentrically loaded and it's more than they can bear, so they will be traumatized to grade 1, 2, or 3, and then go into spasm, and then you've got the stiff neck again. Sternocleidomastoid. From here I'm also going to look at the upper third of the traps, which is more posterior, and we'll come back to that. Upper third of the traps. Out here, for any tenderness, don't just touch it, touch it, touch it. No, you're milking the whole thing. And you can do it with a sweep with some pressure. From here we're coming out to the, we're also soft tissue, the ligaments and capsule around the sternoclavicular joint. Inferior aspect is the origin or proximal attachment of the pecs, nothing on top. When you hit the concavity and it starts around, it's there. Step off anterior is the origin of the anterior deltoid. Coming down to the deltoid tuberosity, where you see the, actually this is designed so the ballroom dancer the lady can put her hand right there. That's why we have that. Anyway, and you're looking for the girth there with the anterior deltoid and palpating the whole thing. Stepping off the lateral aspect of the clavicle, middle deltoid, and I'm watching the countenance. Stepping off the posterior chromium, and we have the, from clear up, about a third of the spine of the scapula and the acromion, it steps off and comes down around. Again, all three deltoid, that's what it means, like a delta down to a point right here. And feeling their girth and symmetry, size, shape, relationship. Anteriorly, locate once again the greater tubercle, tuberosity, and the lesser. And there's the dip. Now there I can feel the long head of the biceps. And we will do special tests later to distinguish that from superficially pecs and deltoid, etc. But follow it on down, biceps 2 heads, one comes over to the coracoid process, which you've learned how to touch, and follow it down. Please turn your palm up and push against my hand. There, an isometric, you can see that standing out right there, and relax, palpate it all the way down into the bicipital tuberosity on the proximal end of the radius, where it ties into the radius. It spins the radius to do supination, pronation, rotates it. Anterior view, going posterior. Let me have you stand, please. And right here. Good. Going to bring you over here a little bit on an angle. Again, looking for symmetry, and we've already done a visual inspection. Notice I don't look, I'm just listening with my fingers, knowing what I'm going to come to. Superficially, upper third of the traps from the occipital ridge down to about the flat aspect of the vertebral border of the spine of the scapula is the upper third, and it ties clear out along the spine of the scapula. Deep to that here is supraspinatus in the supraspinatus fossa, and deep over here is levator scapulae. Everybody likes massage here because we carry our tension here, typically upper traps or levator scapulae. Coming down from this, the traps continue from the spine clear down to T12. At T12 they angle up over to the inferior angle of the scapula and then dive over to the spine of the scapula from here. So it's the lower third, middle third, upper third. Upper third are military press, scapular upward rotation or elevation.
Middle third, scapular adductors, A44. Lower third, assist with upward rotation and scapular depression. Is that amazing or what? Or what? From TC7, rhomboids minor, come down to the triangular space on the spine of the scapula, right there. So C7 down to here, and then they're all in parallel like this. You cannot distinguish the rhomboids from the traps. The traps are superficial. Both of them do scapular adduction. A muscle can only pull, it cannot push. You can relax the arm and get loose. Let me hold it there. Perhaps. There we go. Now I can get clear underneath, and there is the subscapularis and serratus anterior. Depends on the person how far you can get. C7 down to T5. Parallel like this, deep to the middle traps. And the lats we have already done, which comes clear down to the iliac crest, and the lumbar fascia twists upon itself up into the groove, the bicipital groove floor. And those are the soft tissues assessment of the shoulder girdle. Good luck to you.